Hello, everyone, and welcome to the Premier Medical Plaza. We're so glad to see you here. We're glad that you're interested in our monthly Lunch and Learn program. I'm Mary Beth Nelson, and I see a lot of familiar faces out here, as well as some new ones. We do provide this complimentary Lunch and Learn series each month for the employers in our area as well as the members of our community. And I just want to say thank you so much for making this program a success. Our first program was done, I believe, in October, and it's been very well received and attended since the beginning. And I would like to turn the microphone over for just a moment to Sherry Nance. She's the Director of Premier Imaging, which is located in the lower level of this building. She is one of our sponsors today. So thank you again for being a part, and I'm going to hand the mic over to Sherry. Thanks.
Hello, everyone. We're glad to be a part of the sponsorship for these meetings, and I'm so glad you all are attending. Please enjoy your lunches. And we're located on the bottom floor. We're Premier Imaging. We have digital X-ray, digital mammography, and CT, MRI, ultrasound, and bone density. So we like to have the one-stop shop feeling while you're here in the building, seeing other doctors as well. We do Mam and Glam events as well for businesses. We just hosted one recently with a business on Tuesday, which was a lot of fun. And what those are you come in for your screening mammogram, and then you have like a massage, a beauty consult, all kinds of fun stuff with it to make it not such a, I'm coming in for my mammogram experience. So we try to make those as fun as they can be. So we've got cards over here if you want to pick one up and give us a call about that if you're ever interested. And just come and try us out. But I'm so glad you all came today, and we're happy to be a sponsor for this event. I'm going to turn it over to Jennifer.
Hi, everyone. I would like to welcome you on behalf of Cornerstone Healthcare. My name is Jennifer LeBeau, and I work for Cornerstone in administration. Today, I have the honor and privilege of introducing to you your speaker, Dr. Richard Sater. Dr. Sater works in our Cornerstone Neurology office. He received his undergraduate degree at the University of Florida, his graduate degree at Duke University, and also his medical degree at Duke University. Dr. Sater is board certified by the American Board of Psychiatry and Neurology. His subspecialties and interests include clinical neuropsychology, pain management, multiple sclerosis, headaches, and sleep medicine. Dr. Sater, we are all thrilled to have you here today. Everyone join me in welcoming Dr. Sater.
First of all, I'd like to thank Cornerstone and High Point Regional for sponsoring this talk, and everybody for showing up today. I'm going to be giving an overview of various topics in sleep medicine that may be of interest to either people in the audience or people or their spouses, and because sleep issues often affect men more than women. I've put this talk to be about 30 minutes, which will leave plenty of time for questions, but because of the size of the group, if anybody has a question at any time, just speak up. So first I'm going to talk a few minutes about sleep in general, and then focus mostly on the major sleep disorders which we see in the clinics, and that includes sleep apnea, insomnia, problems with sleeping too much, like narcolepsy or hypersomnia, and also problems with restless leg syndrome. And of course, we'll talk about the treatments with those as well. So first of all, why do we sleep? Sleep is not something unique to people or even to mammals. Reptiles sleep. Even insects have something resembling sleep, where there will be a 24-hour cycle in how different processes in their body will be. So sleep most likely serves several purposes. First of all, it gives the body a chance to physically repair itself. During the 6 to 8 hours of sleep, a lot of processes can occur in the body, including repair of muscle damage, other changes, And it also seems to play a very important role, at least in mammals, in memory, in that disruption of sleep can affect memory, and especially disruption of the dream sleep. So we know several things about how important sleep is. If you take a simple mammal like a mouse or a rat and prevent the mouse or rat from sleeping, within a week the animal will most likely either be dead or near dead. And the reason is that the immune system in these animals is very much tied into sleep. And 1 to 2 weeks later, a mouse or rat will have severe infections and then die. So, sleep is clearly playing an important physical role, and not just in making us feel better the next morning, but in repairing the body and letting various functions occur. Now, in most mammals, sleep is consolidated in one long section of time. So in people, of course, we typically consolidate all of our sleep in 6 to 8 hours. And in fact, usually by the time we're about 6, that's the case. Obviously, babies require 14 hours or so of sleep, so it's going to be over multiple time periods. And other mammals, though, don't consolidate their sleep. So cats and dogs will sleep throughout the day for shorter periods of time. There are 3 different types of sleep in people. We call it light sleep, deep sleep, and rapid eye movement sleep, which is and basically light sleep is where we probably spend about half of the night, deep sleep about a quarter of the night, and rapid eye movement sleep about a quarter, unless you have a sleep disorder, and then you're also spending a fair amount of that night being awake. And basically, the rapid eye movement sleep is when the most vivid dreams occur, and that seems to play an important role in memory. So that if you take people and you don't let them have rapid eye movement sleep, their memory may not be quite as good. And deep sleep seems to be what makes us feel better the next day. So people who don't get enough deep sleep usually just feel more tired throughout the day. And light sleep seems to help us a little bit, but not much. So it may help us, it gives our body a chance to repair itself, but light sleep just doesn't do it. It just doesn't make you feel that refreshed the next morning. So the way that we measure sleep is with what's called a polysomnogram, or PSG. A polysomnogram is also just referred to as a quote-unquote sleep study. So if you go to a sleep lab and you have a polysomnogram, we're going to be looking at different things. The main part of a sleep study is to look for how the sleep is arranged. Are you sleeping most of the night? Are you asleep, awake? Are you having the normal amounts of deep sleep and REM sleep? Are they occurring in the appropriate cycles, or are you constantly waking up back, awake sleep, wake sleep, wake sleep throughout the night? We're also looking for what's called sleep disordered breathing, and the main sleep disordered breathing is obstructive sleep apnea, and that is by far the most common reason a person would go to a sleep lab. So if somebody snores and they're tired, there is a good chance that they have sleep apnea. Now that doesn't mean it's bad enough that it needs to be treated with a face mask, but a combination of snoring and being tired, most men who complain of those 2 symptoms will probably have sleep apnea, and a fair amount of women too. And I'll talk a little bit more about that in just a minute. The other thing we look for is, as long as we have you there, we may as well try to get everything done in one night and try to look for other aspects of sleep. So there'll be some electrodes on the leg where we'll look for restless leg syndrome at night. And we also look for other rarer things that some people act out their dreams. So instead of just being quietly in bed dreaming, and just their eyes moving back and forth during the rapid eye movement sleep, their whole body is involved in the dream. So they may actually get out of bed, run around the room, pound the person next to them, yell out in their sleep. So, we're looking for those type of things as well. And then, sometimes other things just show up. We're not really looking for them, but things like bruxism, which is where somebody kind of grinds their jaw the entire night. And so as long as you're in the lab, we try to characterize every aspect of your sleep. This is an example of a typical study in somebody young and in somebody elderly. In, let's say, your typical 20, 30-year-old young adult, you're going to have rather good sleep. You'll fall asleep, let's say, and this kind of looks at the length from the beginning of the night to the end of the night. Stage 1 and 2 are light sleep, and stage 3 and 4 are deep sleep. And REM is the thick line which shows up a few times there. And the first thing which is striking is how you'll see that there actually seems to be 60 to 90-minute cycles where somebody will have, let's say, 4 or 5 cycles every night where they go into light sleep, deep sleep, REM sleep, light sleep, deep sleep, REM sleep. And that's a normal, what we call sleep architecture that we see throughout the night. Somebody who is older tends to have much, much less deep sleep and more awakenings. So it's more fragmented. But if we see somebody who's 20 and 30 like this, there's probably a reason why their sleep is not as well as it should be, and we need to figure out why. If somebody has insomnia, it's very important for us to try to tell from the sleep study, are they having insomnia at the beginning of the night or the middle of the night? And things like that can be figured out with this type of study. So, why is somebody going to be tired the entire day? There are several different reasons. The main thing, though, is that it can be, we look at it, is there primary sleepiness or secondary sleepiness? Primary sleepiness is when somebody's sleepy during the day because they have a disorder of wakefulness. Their body just wants to sleep during the day, even though they're getting enough sleep. They're getting good quality sleep, but they're just always sleepy. So there are a couple of things which can cause that. The one that most people have probably heard about is narcolepsy. And narcolepsy is when people have sudden sleep attacks. They will just get an overwhelming need to fall asleep right away, and there's really nothing that they can do to stop it. And sometimes those attacks are triggered by strong emotions. So I can think of a patient who's very jovial. She and her sister get on the phone and they just joke about various things, and she starts laughing and she falls asleep. And then she wakes up a minute later and her sister's laughing at her, so she starts laughing and she falls asleep again. And people just can have the sleep attacks throughout the day, and obviously there's things we can do about that. The other type of primary cause of sleepiness is what's called idiopathic hypersomnia. It's a big word that basically means you're just sleepy. You're sleepy without a clear-cut reason. So idiopathic, whenever you see that in a medical term, it means without a clear-cut reason. So in this case, it's primary or idiopathic hypersomnia. And these people basically don't have all the features of narcolepsy. So they're sleepy throughout the day, but they don't get the sudden attacks. They kind of get drowsy first, and then they just kind of feel like they just need to sleep. They get a nap, they feel better. Primary hypersomnia is just a milder form. And then there are other things that can cause you to be sleepy the next day. And these are causes of bad sleep. You're giving yourself 6, 7, 8 hours of sleep maybe, but it's not a high quality sleep. Either you have sleep apnea, you have insomnia, you have restless legs at night waking you up, but you're having something that's just giving you bad quality sleep. People who have a lot of pain, like people with rheumatoid arthritis or fibromyalgia, sometimes have bad quality sleep. They don't have sleep apnea, they just they're just constantly up, down, up, down, up, down. And when your body's going awake, asleep, you don't get that length of time long enough asleep to get into deep sleep. So people like that just don't have the amount of deep sleep that they need to feel better the next day. And I should mention another thing there is bad sleep habits. Every now and then I'll see a person who comes to me that they're sleepy and they're giving themselves just 5 hours of sleep at night. So even if they're sleeping all 5 hours, they're not going to feel rested enough the next day. And then other people, they lay down at night, but they have the TV blaring, they watch an hour and a half of TV, so it's just not a high quality sleep. So there's clearly bad sleep habits that people need to adjust at times too. So basically, by far the most common reason somebody gets a sleep study done is because they snore and they're sleepy. And when that happens, first thing a doctor is going to think about is, does this person have obstructive sleep apnea? So sleep apnea can be caused by various different things. We know that there are several risk factors. Sleep apnea is not common in children, but it tends to occur more with age. So people who past age 40 are much more likely to have sleep apnea than those in their 20 or 30. So a 20-year-old may snore but not have sleep apnea. 15, 20 years later, they then have sleep apnea. So they're the same, they may even be the same weight throughout, but just with age, they've gone from just snoring to sleep apnea. And we often think of sleep apnea, and well, snoring and sleep apnea are related in that there's very, very few people who have sleep apnea who don't snore. But snoring is much, much more common than having sleep apnea. So it's really a spectrum. With snoring, you have some obstruction in the back of the throat, so that you're vibrating the palate, causing a snoring sound. And so if that becomes a little bit more obstruction, you can have a borderline sleep apnea, which we call upper airway resistance syndrome, because we need to have a name for everything. Now, people with UARS, we usually don't treat, in a major way. But then, of course, you go from that minimal obstructive sleep apnea to mild obstructive sleep apnea to moderate or severe. And clearly, the effects on your health are going to be more for the moderate and severe than for the minimal and mild. Besides age, other risk factors are weight. When people think about sleep apnea, they often think of the overweight middle-aged man with a big neck. And the reason is that the average overweight middle-aged man with a thick neck does have sleep apnea. The neck size correlates with the chance of sleep apnea in a major way. So any man with a neck of 17 inches or more has a fairly high likelihood of having sleep apnea. Any female with a neck size of 16 or more has a fairly high chance of having sleep apnea. And the reason is that neck size correlates with your weight. So, most people who are bigger, they're going to have a bigger neck. And, but it's not only correlating with your weight, but kind of where some of that weight is stored. If stored in your neck, you're going to be putting more pressure on the structures of the neck, including the upper airway. And other people have anatomic variance. Sometimes we see people who, a 110-pound woman or a 150-pound man who has sleep apnea. And you think, well, this person just doesn't look like your typical sleep apnea person. But from a side view, you'll often see a recessed chin. And the reason is that instead of the back of your throat being nice and round, somebody like that may have a back of their throat that's much more oval shaped. And so it just takes a lot less for them to have sleep apnea. Sometimes we even see sleep apnea in children, and almost always in children is for one of two reasons. If they're young children, less than age 12, it's almost always very large tonsils, or they have a very recessed chin, and that's the anatomic variation. If it's after age 12, it's usually that they're very overweight children. And as you know, the crisis in America of overweight children, well, it's not only hypertension, diabetes, it's sleep apnea. And in fact, even things like attention deficit disorder seems to be at much higher in children who have sleep apnea. So, an overweight child who snores, who has attention deficit, one thing that needs to be considered is, do they have sleep apnea? And there's a lot of reasons why we want to treat sleep apnea. It's not just to give the spouse a better night's sleep, okay? Because it's kind of hard to sleep well when you feel you got to constantly be nudging your husband awake. And which actually, since you're only catching probably 1 or 2% of the sleep apneas, you're really not doing much anyhow. The reason that you want to treat sleep apnea is twofold. One is because treated sleep apnea can increase a person's life expectancy by eliminating some bad disorders. And number two, it can make the person want to live longer by feeling better the next day. So the main health issues that we worry about are the higher risk of stroke, the higher risk of heart attack, and the higher risk of arrhythmias, which is one of the main causes of sudden death. So it turns out that among middle-aged men, the risk of sudden death is doubled if somebody has sleep apnea. That's not being adequately treated. And the main reason for that is probably arrhythmia or heart attack. And so those are the major health issues we're trying to treat. Then there are the lifestyle issues. We want a person to be more alert during the day. Somebody who, the Exxon Valdez oil spill, the captain fell asleep while on the ship. Quite a few truck accidents. The person fell asleep while driving. In fact, the most Department of Transportations in states now, if a truck driver is above a certain weight or body mass index, they're required to have a sleep study. And the reason is that the risk of accident in somebody who's driving for 10 hours in something boring like driving for 8 to 10 hours is so much higher if they have sleep apnea. And also things that you may not think about as much. It's not just that the person has less chance of dozing off and causing a major accident, but even if they're awake, a person who's awake who got a better night's sleep night after night after night is going to function better. They're going to do better at work. They're going to do better in their professional and interpersonal relationships. They're going to be less irritable. It can affect lifestyle issues quite a bit, and other things, even things that you may not even think are associated with sleep apnea, such as in men, erectile dysfunction in both men and women, the number of times you have to wake up at night to use the bathroom. So things like that you may not even think about as possibly having a relationship can, and everything on this list has a improved chance of getting better if the sleep apnea is treated versus leaving it untreated. And once again, the worse the sleep apnea is, the more likely you are to affect a person's health by treating it. I should mention depression and other mood disorders can be improved by treating sleep apnea as well. So this is just a little schematic about what's going on in the back of the throat. Most of the obstruction is occurring in the upper palate and the base of the tongue. And it's in somebody who has a normal airway, air can pass through pretty easily. In somebody who has sleep apnea, you can get either the top of the palate, the base of the tongue, or the rest of the upper airway. It closes off. So what happens is, as a person takes a breath, the airway can collapse on itself. And just like sucking through a straw with your fingers on the other end, you know how it causes it to collapse? If you have some obstruction, a little obstruction quickly leads to a total obstruction, and then no air passes back and forth. And that then prevents breathing for a period of time. Sometimes the person even has to wake up and then clear the airway, and then they fall back asleep. So someone with sleep apnea who has a severe sleep apnea, multiple times a night there's going to be reduced air being passed back and forth, and then maybe a breath or two without any air being passed back and forth, followed by a quick snort or gasp that the person wakes up for just a second and then quickly falls back asleep. Now, what happens after that person wakes up? He goes back to sleep. What about the spouse? Okay, so that's part of the problem. So we really try to help everybody out when we're treating a person's sleep apnea. There are several ways, and I should have mentioned a few more I'm going to mention as well, but there are several ways that we treat sleep apnea. The way everybody probably knows the most about is a CPAP, or continuous positive airway pressure. And BiPAP just means bi-level positive airway pressure. It's the same machine pretty much, just a different setting. And basically what these do is they raise the pressure in the throat while you breathe in and out. By raising the pressure, it's equivalent to that same straw which got sucked, poking a hole in the straw so it can't collapse on itself. And then air can pass back and forth. So you're keeping the pressure high so the throat doesn't collapse. And that's really the whole principle of what CPAP does. Now, most people breathe through their nose, but many people breathe through their nose and mouth, or they breathe through their nose but they leave their mouth open. If somebody either breathes through both their nose and mouth or leaves their mouth open, they're going to probably need a mask that covers both the nose and the mouth. If somebody's a pure nose breather, they can often get by with a mask that's really just around the nose, or even what's called nasal pillows, which are kind of like a little cannulas that are attached. However, if the pressures have to be high to keep the airway open, usually, once again, the full face mask has to be used. And there's a lot of personal preference. I can't look at a person and know what type of mask they would ultimately choose. So it's a combination of personal preference as well as what works. And a lot of people think that they're going to hate their mask. And it turns out probably about 4 out of 5 people who get started on CPAP therapy really like it from day one. And then of the other 1 out of 5, about half of them will eventually get used to it, and about the other half, just whatever we try, nothing will work. Most people are going to love their CPAP if they feel better. So the people who are sleepy during the daytime like CPAP more than people who are not sleepy during the daytime. And it's like a lot of things. You are more likely to stick on a medicine that you feel it working. Why do people go off of their blood pressure medicine? Because they don't know it's working. Whereas diabetics, because they're constantly sticking their fingers, are much less likely to stop a medicine. And same with the mask. You're going to stay on it more if you know it's working well. And then other things can be used. One thing, for the people who have moderate or severe sleep apnea, if the face mask does not work, then the next best treatment is surgery. And I should have mentioned that on this list. It's just not listed there, oversight. But the surgical approach is probably it's not the gold standard, but it's the silver standard. So it's almost as good as CPAP. For many people, it's just as good. Some people just either don't want to have a mask the rest of their life, or they just can't get used to the mask. But what sometimes happens is that you get rid of the worst obstruction, and then the second worst obstruction starts to play a role. So sometimes surgery only reverses things somewhat and not completely. And then an oral appliance, these are hinged retainer type of appliances that basically pull your lower jaw outwards, giving the back of your airway a more round appearance, and that can just let you pass air back and forth. Oral appliances are wonderful for mild sleep apnea. They tend not to be that effective for moderate or severe sleep apnea, just not effective enough. So we don't think of that as much as a first-line treatment as we do. And then the other thing is, still, it's not going to be as effective as CPAP, but it is a good option for people who have minimal or mild sleep apnea and don't want to use a face mask. And then positional therapy. Sometimes when we do a sleep study, this is why sleep studies done in the doctor's office, in the sleep lab, have a lot of advantages over like trying to get something done in the home where you only get partial measures. You're just really looking at is there apneas or not. Is that we can sometimes help people avoid having to use if we find that 100% of their sleep, well, let's say 95% of their sleep apneas occurring on their back, well then, if they're able to sleep on their side, and almost all of the sleep apnea is occurring on the back, by using positional therapy with special pillows or other type of aids, can help a person control their sleep apnea and get a good night's sleep. And then, so I mentioned the surgery, and there are actually some medicines. Sometimes if somebody's sleep apnea occurs only during rapid eye movement sleep, some medicines can reduce the amount of rapid eye movement sleep and hence help the apnea. Once again, that's not an option for moderate or severe sleep apnea, but for milder ones. So the next thing I wanted to touch base on is insomnia. Sleep apnea is probably 3 to 1 men to women. Insomnia is probably 3 to 1 women to men. And it is a very, very common disorder. But luckily, not everybody who has insomnia has a severe insomnia. So probably half of the people have some type of insomnia, but often it's situational. They just will have a transient insomnia. There's stress in their life. They're not sleeping well. That stress gets better. They sleep better. Everything's fine. Probably no real doctor's visit might be necessary. No real intervention might be necessary. Sometimes so the transient insomnia often can be treated very easily because it's not that much a part of the person. Chronic insomnia can be a little bit more tricky. Chronic insomnia is occurring pretty much every night or more than half of the nights. And we look at insomnia 2 different ways. Is it trouble falling asleep, trouble staying asleep, waking up too early, or a combination of 1 or 2 or 3 of those factors? And often it's a combination. And if somebody has trouble just falling asleep, some medicines may help that better than others. If somebody has trouble staying asleep, some medicines are better for that. And then a certain subset of the medicines may help both. But sometimes you don't necessarily need to treat with medicines. I'll talk about that in just a minute. As far as the actual causes of insomnia, there's quite a few different things. The major cause, I think, is poor sleep hygiene. Just people don't. They're working on their computer in bed. They're watching TV for an hour and a half in bed before falling asleep. So what's happening is that you're turning your bed into your living room. And then it's harder sometimes to associate the bedroom with falling asleep. And so if you wake up in the middle of the night, you may feel you've got to turn the TV back on to fall asleep. Or then it's going to be harder to do so. Some people, they have a lot of light in their bedroom, and other people don't give themselves enough time to fall asleep, or they have a very variable schedule. Sometimes they're trying to go to sleep at 9, sometimes they're trying to go to sleep at midnight. What always fails is the person who usually can't fall asleep till midnight but then feels tired, so they say, well, let me go to bed at 9, then I'll get an extra hour or 2 of sleep. But they're not going to fall asleep until midnight anyhow. And then they just gets more frustrated. And what happens a lot of times is that the most common cause of insomnia is kind of like a combination of psychiatric and physiologic. And so a person has trouble falling asleep for whatever reason. They then adjust to it by getting frustrated. Then when they're frustrated, they have more trouble falling asleep. And that cycle is so common in a lot of the people who have a chronic insomnia, where they have this inability to just relax and fall asleep. And I should mention also pain. Chronic pain can be a reason to have trouble falling asleep. And then, of course, people who have shift work, where their schedule is constantly changing, there's actually the circadian rhythm, is the 24-hour rhythm that your body follows. If you have shift work, it's not following. I mean, just by the time you get used to it, you got to change your schedule again. And then what happens is a lot of people, they work, let's say they work nights, but their family's on days. So during the week, they do okay, but then on weekends, they're trying to match their family's schedule, and then they get all messed up again. And your circadian rhythm can't just change in 1 or 2 days. It often takes 3 or 4 days for that to shift again. So treatments are kind of based depending on what seems to be the issue. Obviously, a quick discussion about sleep hygiene issues. Are you making the bedroom, or are you making it the living room? Are you giving yourself the right amount of time to fall asleep? If you can't fall asleep, what do? Are you getting frustrated? Well, if you're getting frustrated, you're not going to fall asleep anyhow. Get out of bed. Do something for 30 minutes, then go back to bed. You'll actually sleep better often doing something like that. Just getting out, doing other things, and then going back, because it gets rid of that frustration factor. And so cognitive behavioral therapy is a combination of some of the ways of dealing with insomnia, as well as dealing with some of the anxiety that may be making the insomnia worse, and some techniques such as visual thinking that may help you to relax in order to set your body's mood to fall asleep in the first place. And then other problems, if somebody has anxiety or depression or pain that's making sleep worse, they often have to be addressed, or else there's not going to be a good night's sleep. And then medications, many different types. I mean, I'm not turning this into medication talk, but depending on whether it's sleep onset problems, sleep maintenance problems, or a combination of onset and maintenance, we would pick different medicines. Restless leg syndrome is actually a spectrum that combined with periodic limb movements of sleep. Everybody's probably heard of restless leg syndromes, where hardly anybody's heard of periodic limb movements of sleep. It turns out that about 90% of people with periodic limb movements of sleep have restless legs, and about 80% of people with restless legs will have periodic limb movements of sleep. So they're really a spectrum of the same thing. It's just restless legs mean you feel the urge to move your legs because of an uncomfortable sensation while you're awake. So that usually happens in the evenings. It usually happens when you're forced to be still. So restless legs can be especially bad when you're driving or flying and you're just not able to move around. So during the daytime, if you get an urge to move, it's very easy to just get up and move around. In the evening, you want to try to, you're kind of trying to relax more. You don't really want to get up and be moving around, but moving around will often help. And then the periodic limb movements of sleep is really the same thing, but it's happening while you're asleep. But what happens is that sometimes when you move at night, it's going to wake you up. Sometimes it's going to wake your spouse up as well. But if the periodic limb movements of sleep are waking you up, it's going to give you a worse night's rest. So you're not going to have as much deep sleep. You're not going to feel as rested when you wake up in the morning. So restless legs and periodic limb movements, it turns out we use the same medicines to help both. Sometimes we'll test for iron, and if somebody has a low iron level, treating the iron can make a huge difference. This is more common in pregnancy. So if somebody's pregnant and has restless legs, then it probably will get better in a few months, and you'll just substitute one reason to have trouble falling asleep with another. So this tends not to be like a major health issues. People don't die of restless legs. They don't die of periodic limb movements of sleep, but it can give you lesser, can make you not as comfortable during the day and not as comfortable at night. The hypersomnia disorders, I briefly touched base with this earlier on. These are not that common. Narcolepsy is probably only 1 out of 2,000 people or so. So it's not at all a common disorder, but probably 1 out of 200 or 300 might have primary hypersomnia. And basically with narcolepsy, as mentioned, people will have the cataplexy, which is sleep attacks. But it turns out narcolepsy has some pretty major abnormalities in in the way that your brain is controlling sleep. So at night, people with narcolepsy, you would think they would be sleeping wonderfully at night because these people love to sleep. But it turns out their sleep is very disrupted. They often will have insomnia mixed in with sleeping at night. And so they have a very disrupted sleep. They can have hallucinations when they're drowsy. Basically what happens is that narcolepsy is a problem with that rapid eye movement sleep. What's happening is that rapid eye movement sleep is occurring when it's not supposed to occur. It's only supposed to occur when you're safe in your bed. Okay? It's not supposed to occur when you're awake. And so people with narcolepsy, when they get drowsy, can actually have those dream-like episodes. And then during the day, as they shift into sleep, when you have rapid eye movement sleep, your body paralyzes itself. So during rapid eye movement sleep, you should not move hardly at all. And that's good because you're not going to act out your dreams. But what happens then is that when that happens during the daytime, it will cause people to have those sleep attacks, and they just kind of lose muscle tone at the same time that they fall asleep. And that can be dangerous. So somebody with narcolepsy who's very angry or laughing, because those cataplexy spells are almost always triggered by emotion, can actually hurt themselves by falling on the floor or other things. And then primary hypersomnia, basically these people, when you look at their sleep at night, is fairly normal. It doesn't have to be completely normal, but it's fairly normal. They're having deep sleep, they're having rapid eye movement sleep, they're having those 90-minute cycles of sleep. Whereas narcolepsy people won't have those nice 90-minute cycles. But so it looks like they just shouldn't be tired. Somebody's getting 8 hours of sleep, sometimes 13 hours of sleep, and they're still tired. So often this is something where we'll do a different type of test in the sleep lab called a multi-sleep latency test, and we do that for narcolepsy too, where we try to see how fast does a person fall asleep. Somebody with narcolepsy may fall asleep in a minute or two. Somebody with hypersomnia may fall asleep in less than 5 minutes. And this is during the daytime. Most people during the daytime would only have maybe once, if they tried 5 naps throughout the day, may only fall asleep once within 15 or 20 minutes. But people with these problems will fall asleep every time. And both of these problems are treated medically. Narcolepsy can be a serious issue. You don't want somebody falling asleep while driving, so it's something that definitely has to be treated. Primary hypersomnia, sometimes if somebody gets better just by taking a nap during the day and they have a schedule which allows that, then maybe medicines won't have to be used, but there are medicines that can keep a person alert as well. So I'm going to stop here and just open things up to any questions about any aspect of sleep. And I do just want to, before doing that, just mention that sleep studies, a lot of people are all concerned about, I'm going to be hooked up to everything, will I be able to fall asleep? And almost everybody is able to fall asleep, hooked up to everything. Obviously, people with insomnia are going to have a little bit more insomnia because it's going to be a higher anxiety. There's going to be a little bit more discomfort. So, some people, in like our sleep lab, and we actually have 2 beds here and 4 beds in Westchester, but that we can give a sleep aid, but not after midnight. So we always want people who are having trouble falling asleep to let the technicians know so that something can be given, because after midnight you're kind of on your own. We don't want to have somebody driving home at 7 the next morning after taking a sleep aid at 2 in the morning. And but the procedures itself, the rooms are kind of like hotel rooms, with what we hope is a comfortable bed. If you do have a sleep study, or if your spouse has a sleep study, if they have a favorite pillow, it's not a bad idea to bring that. Whatever sleep clothes you might sleep in generally can be accommodated. People often ask, can their spouse come? Well, it doesn't work out very easily, okay, to do that. If there is a mentally retarded person, we often will have somebody else in the room. If there's a teenager, we personally don't do younger children, But then sometimes it's okay to have somebody else in there. But it is. Those are some of the questions people ask. So I'm just trying to answer those questions right away. And and of course, if you think you or your spouse may have a sleep issue, should be discussed with your doctor. And if a sleep study is recommended, it's not really a big deal. And then if something's found, they may or may not want you to see one of the doctors who specializes more in sleep. Okay, any questions? Over there.
I can do without the sleep.
What's that?
I can go without sleep for days, for weeks.
Yeah.
And I'd rather not take a pill.
Right.
And I'm energetic.
Yeah. Well, there are what's called natural short sleepers.
My dad was like that.
Yeah, and it does run in families. Turns out that a lot of people will have measurable drop-off in function, but others really don't. And even though the average person needs 7 hours of sleep, so there are certainly people who can get by with 4 hours of sleep on an average basis and really do just fine. And Thomas Edison was one. He slept like 3 to 4 hours every night for his whole life. And I think my daughter's like that because she just doesn't sleep and she functions just fine. And
High school,
yeah,
I did it.
yeah. And it generally, as long, insomnia is an interesting thing because the definition of insomnia is difficulty either sleeping, or you either falling asleep or maintaining sleep, and that it impacts your life. And that's the key, is that it impacts your life. So if you have trouble falling asleep but it doesn't impact your life, is that really insomnia? It could just be that you're a short sleeper. And some of those hypersomnia people are long sleepers. They just need 14, some of the people who have the primary hypersomnia are long sleepers. So some people who are long sleepers, they need 12 hours of sleep, and if they get their 12 hours, they're just fine. But then there's others who, even with 12 hours of sleep, are not fine.
Right.
And at some point, you got to wake up.
With that mental
Yeah, exactly.
depression,
But sleep is a very variable thing. Okay?
How long does the study take? How long
Yeah.
are you there?
Generally, when you have a sleep study, you come in around 9 p.m. and you leave around 7 a.m. So typically, it's just one night, and we try to get things done in one night. If somebody has a moderate or severe sleep apnea, most of the time we're able to, sometimes people don't have a lot of sleep apnea in the first half of the night. If somebody has a lot of sleep apnea in the first half of the night and they were ordered to have what's called a split night study, we try to do everything in one night. So the first half of the night we diagnose sleep apnea, the second half of the night we'll use the mask. Sometimes though, if somebody has a mild sleep apnea, we can't really say they have enough sleep apnea, and because there's so many options, you don't necessarily get everything, it's not standard to try to get everything done in one night. And then sometimes somebody may have a moderate sleep apnea, but their worst sleep apnea occurred at between 3 and 5 in the morning. And by the time it was bad enough to count, there's only an hour or two left, and you need more time than that. But so basically you come in around 8:30 to 9, you get hooked up, and anytime you're ready to go to bed. Some people watch an hour or so of TV. If somebody's used to going to bed at 11 o'clock, they're not going to be able to fall asleep at 9:30. Generally they like everybody pretty much to be trying to fall asleep by 11 o'clock. And then starting around 6 o'clock, they'll look at the 2 to 4 people in the lab and try to figure out who should they wake up first, and because they like them staggered by about 15 minutes to wake up everybody to get disconnected. In the sleep lab we have at Westchester, every room has its own bathroom and shower. So you can take a shower the next morning, and bring the extra change of clothes, and you don't even have to head home. You just head straight to work. The one here, we have a shared bathroom and shower, but there's only 2 beds.
It has to be doctor prescribed to have it done.
Yeah, Yeah, I mean, a lot of different doctors can order it. It doesn't have to be your primary care. Any specialist a person may see, their OB-GYN, and here's something which can be ordered by any specialty. But I mean, it has to be ordered by somebody. Now, some companies will do it, like some trucking companies do it as part of, a screening, and that's a different thing.
How's the insurance coming?
Usually it's covered pretty well. Almost everybody's insurance covers it just like a doctor's visit. Of course, everybody is different with deductibles. You know how some people have high deductible plans, and if but an insurance search is done for everybody so that when you get scheduled, if you have a concern about that, it can be looked at. But the vast majority of people will have it covered. Similar to like having an MRI done. So some people with high deductible plans, it's a shock. Other people, it's just a $30 copay or something like that. Okay.
I've gone to two sleep studies with my son up by Wesley Long Hospital.
Okay.
It's a big sleep study center up there in Greensboro.
Yeah.
I've gone to two, and it's very nice. It's like hotel setting and recliner chair for me, and
Yeah.
and they give sheets and towels, and
Right.
and they have a private shower.
Yeah. I mean, most of them.
Bed for my son.
Yeah. It's usually a pretty nice room, like a hotel room.
With TV, and it's real nice all night. I can watch TV. and
Right.
Turn it down low.
Right. And with pediatric studies, it's typical to have the mother in the room with them.
And he has had it since he was 30, so he's very overweight.
Okay.
Borderline diabetic.
Yeah.
And has a mental condition.
Yeah.
He developed that at 30.
Yeah. Okay. And it being overweight is a risk factor as well.
He uses a CPAP, but he won't use it all night.
Right. Yeah, that can be a problem.
It's uncomfortable, I guess.
It works only if it gets used.
And another thing, my uncle has it. Is it? I want to know, is it a question? Is it maybe hereditary? My uncle has it.
Yeah.
My
There's
sister
a mild amount of hereditary. It's like a lot of things. Let's say hypertension. Some families, it seems, or diabetes, or so many other things. Some families definitely have more of it, but it's not like let's say sickle cell anemia, where one gene you can say with certainty does somebody carry the risk or doesn't carry a risk. So it is something where you can inherit a little bit higher risk, but it's still, somebody who has a higher risk and is thinner may not have it. And even identical twins, sometimes one will have it, but most times with identical twins, if one has it, the other one's going to have it too. Okay? Right, over here.
Now, did you say that they actually hook you up to something while you sleep?
Yeah, so basically you will have, let's say, 6 electrodes on the scalp, like having an EEG, like the seizure test, 6 electrodes, 1 or 2 little sticky pads on your legs, 2 belts, 1 around your chest, 1 around your abdomen, and the like nasal cannula for the oxygen. It's not oxygen, but it's a nasal cannula that actually measures the pressure of your breathing. So when you breathe out, it actually sees that you're breathing in and out. And so those are, I may have left something out, but that's so you're kind of hooked up to a few different things. And then most people though actually have no trouble at all falling asleep.
Well, it's not falling asleep, it's getting up, going to the restroom.
It's actually, everything gets hooked into a box, and then the box has one like plug. So if you need to go to the bathroom, you just, there's one technician for every 2 patients. So, and there's a little video monitor. So I mean, you get up and there's like a microphone. You just kind of say, hey, I need to use the bathroom. They'll be in 30 seconds. And then they'll just disconnect that one plug, and then they'll just reconnect the one plug.
Now, what if you're an early riser?
Not a problem. I mean, sometimes people will want to get up and be out by 5. That's fine. Generally, of course, you want there to be enough time to diagnose things. But often, 4 hours is often all it would take. But I mean, we're not going to kick you out at 3 in the morning. So, usually if you're doing well and you're asleep, they're just going to let you do it. But if you tell a technician in advance that you need to be out of there by 5:30, they'll get you up in time.
They have us up by 5 and
Yeah.
we get out by 6.
Yeah,
My son
it
died.
varies. I mean, we start waking people up at 6 and we try to get everybody out by 7.
And that's early.
Yeah. Okay. Yeah. Yeah. How do you put it?
Yes, if you take Ambien and go to sleep, and you're still laying there for hours.
Yeah.
Is there something better than Ambien?
Well, that's a very specific question, hard to answer without knowing a lot of different things. But Ambien's a wonderful medicine to help you fall asleep. The average person does very well with it, but some people it just doesn't help as much. Sometimes the dose can be increased and everything's fine. Other times some other medicine might work better. But often a combination of medicine with some other things, so you have to look about, are you doing some of those sleep hygiene issues, like not using the bedroom as the living room and having a good, quiet, dark environment. Are there some other things which might help? If there's a lot of anxiety, sometimes that anxiety has to be addressed too. And sometimes you're probably one of those who starts out having some trouble sleeping, and shortly thereafter you get frustrated that you're still awake, and then that frustration will make it worse. Yeah.
I'll lay there
Yeah.
for hours.
And and then you get frustrated, and that makes it harder to fall asleep. So sometimes there has to be more than one thing done to break the cycle. And some medicines can make it harder to fall asleep. So that's why it's really hard to answer that question. It's not like there's something better. It's just that
I
there's,
didn't even know that there were
yeah,
dosages, so
Yeah.
there's actually different dosages.
yeah. But it is something where, if one thing doesn't work, if one thing doesn't work, if a higher dose doesn't work, then you have to try something else.
Interesting observation. My husband has restless legs.
Yeah.
And people's pharmacy, the newspaper recommended a bar and soap under the sheet.
Yeah.
It worked.
It did?
It worked.
I've had a couple others that say that too, and that's been something where I've had people tell me it worked, and I've had people tell me it didn't work. So it's one of those things where, hey, it's easy, it's cheap, doesn't have side effects. And the feet will probably be just a little bit cleaner in the morning. Yeah.
I went to the doctor a while back for snoring,
Yeah.
and she recommended me to go to ear, nose, and throat doctor. And I went to them, and they did surgery, which didn't help at all. So now,
Well, probably, it would,
and I don't feel like I get a deep sleep.
right. I mean, it would probably be reasonable to ask for a sleep study. And if the sleep study shows you have sleep apnea, treat the sleep apnea. If you don't have sleep apnea, as mentioned, there's a spectrum from snoring. Yeah. Yeah.
To do it for some reason.
Yeah, but probably because you had the surgery and they're just thinking it should have fixed things. But if not, then let's say you just snore. You don't have sleep apnea, or that you have that upper airway resistance. But then that oral appliance might be a good thing. And there are definitely people who, there's some people who, with the CPAP, we make them 80% better, but they're still real bad. And then sometimes people can have a combination of surgery and CPAP, or oral appliance CPAP, or oral appliance and surgery. Sometimes it takes more than just one thing if somebody has a severe sleep apnea.
I don't feel like I get the good sleep that
Yeah.
I should.
I think in that thing where you're still feeling unrefreshed, it would be reasonable, because, like I said, if you have sleep apnea, then that should be treated. But if you don't have sleep apnea, then the oral appliance would be the next best thing.
I was diagnosed with severe sleep apnea.
Uh-huh.
My question is, because my husband passed away and I've been put on the CPAP
Right.
since, does that stop you from snoring?
It does.
Does it?
It does. In
Okay,
fact,
pressure?
when we do the CPAP titration, as we go up in pressure, they're looking at two things. As mentioned, you have a spectrum. You have snoring, upper airway resistance, sleep apnea. So as you go up on pressure, the sleep apnea gets better and then hopefully goes away. And then the snoring, some people can still have a little bit of snoring, but better snoring as it goes away. And then you just increase just slightly higher on the pressure and the snoring goes away. We usually aim to get rid of the snoring, but we know we have that little window from when we got rid of the sleep apnea to when we got rid to the snoring, and anywhere in that pressure would probably help. But we try to actually increase it. Well, the dial is the humidifier usually. The pressure usually has to be set by the technicians. But you know, if you probably either stopped snoring or got much better. And I mean, it's still obviously if somebody just has a few snores, we're not going to worry about that.
Okay, I was just curious.
Okay. Uh-huh.
My son, he just turned 7, and I have to wake him up through the night. He is like a deep sleeper.
Right.
To the point we even set the alarm, it's right there by his ear, and we can hear it in other bedrooms, he's just still asleep. I mean, what is it, I mean, can he get asleep?
Wait till he's a teenager. Okay, but basically, it's okay. It doesn't mean anything bad. Children.
Two times through the night.
Yeah, I mean, children often just will have the deepest, most wonderful sleep that, you know, when he's 30 or 40, he'll wish he's able to sleep for that way. But it doesn't mean necessarily anything bad. It's just that, you know, it's just hard to wake him up. Make sure he's getting enough sleep. I mean, a 7-year-old should probably get about 8 to 9 hours of sleep. Well, probably closer to 9. Okay? Well, thank you. Okay.
Thank you, everyone. Thank you.